I am the director of the Program for Research on Black Americans. And the Program for Research on Black Americans, along with the Michigan Center for Urban African American Research, are pleased to host this seminar series, which is the Research on Group Dynamics Seminar Series. This is the longest running seminar series in the social sciences. Today, we are really pleased to co-host this with the annual Social Work Winkelman Lecture. I just have one quick little announcement. We have a lot of, again, we have a great speaker today, but we also have a lot of other great speakers coming in, including next week, Christy Irving from Vanderbilt. And then after that, Tyson Brown from Duke. And then after that, Mosi Infantucci from University of North Carolina. And so now I'd like to introduce the Dean of the School of Social Work, Dr. Lynn Davis.
Thank you. Thank you, Robert. And welcome, everyone. It's really a pleasure to be joining with our colleagues at ISR to be hosting this event and to be hosting Dr. David Williams. What an honor. I want to welcome you to the 2019 Leon and Josephine Winkelman Memorial Lecture. Thank you for joining us this afternoon. The Leon and Josephine Winkelman Memorial Lecture was established in 1978 at the University of Michigan School of Social Work with an endowed gift from Stanley J. Winkelman and his brothers as a memorial and tribute to their parents. Stanley's father, Leon Winkelman, co-founded Winkelman Stores in 1928 with his brother Isidore. Stanley's mother was a 1919 graduate from the University of Michigan School of Social Work program, and we're celebrating our centennial next year in 2000.
Check to see if it's in the room that I was just in.
We had a program earlier, about 100 years we established the MSW.
Okay.
So Stanley's mother worked at Hull House, a settlement house in Chicago. And to all of us social workers and community activists, Hull House is still the inspiration today for the community work that we do and the activist work that we do. The Winkelman Lecture provides a forum for presenting new and emerging knowledge from the social sciences and the helping professions in the field of gerontology, and also for discussing the application of this knowledge to developing social policy, the organization and management of social welfare services, and the delivery of social work services. Stanley J. Winkelman was a leader in civic affairs in Detroit. After the 1967 riots sent other retailers to the suburbs, Stanley kept his family's department stores in the city, hoping that their presence could contribute to and sustain an environment suitable for doing business. Mr. Winkelman was deeply involved in social justice issues throughout the city. In 1963, as part of the Detroit Commission on Community Relations, he called upon the Detroit Board of Education to hire more black teachers and to further desegregate Detroit's teaching force. Stanley passed away in 1999, but his legacy lives on in the Detroit community and at the University of Michigan. We are thankful to the Winkelman family for their support of this important annual event that informs our profession and provides us with the opportunity to honor our alumni, Josephine Winkelman and her husband, Leon. This afternoon, we're honored and thrilled to have as our keynote speaker, Dr. David Williams. A note before I introduce Dr. Williams. Following Dr. Williams' presentation, we have brought together a panel of experts from a variety of fields to provide their unique perspectives on Dr. Williams' remarks. School of Social Work Professor Robert Taylor, whom you just met, will serve as moderator for the panel and discussion. and he will introduce the panelists. It is now my pleasure and honor to introduce our keynote speaker, Dr. David Williams. Dr. Williams is the Florence and Laura Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He is also a Professor of African and African American Studies and a Professor of Sociology at Harvard University. Dr. Williams is an internationally recognized authority on the social influences on health. He is the author of more than 450 scientific papers. That should be an inspiration to all of us. His research has enhanced, I would say transformed, our understanding of the complex ways in which race, socioeconomic status, stress, racism, health behavior, and religious engagement can affect physical and mental health. The everyday discrimination scale that he developed is still, to this day, one of the most widely used measures of discrimination in health studies. His research has been featured by some of the nation's top print and television news organizations. His TED Talk, released in 2017, has over 1.2, in fact, it's more than 1.3 million views. I had to just watch it myself this morning, and I'm recommending it to each of you who haven't seen it yet. Dr. Williams has received numerous prestigious honors and awards and has served on a number of national committees, including the National Academy of Medicine, now part of the National Academy of Sciences, that produced the Unequal Treatment Report. He also served as a staff director of the Robert Wood Johnson Foundation's Commission to Build a Healthier America. And he served as a key scientific advisor to the award-winning PBS film series, Unnatural Causes: Is Inequality Making Us Sick? Please join me in a warm welcome for Michigan's own Dr. David Williams.
I want to say thank you to the Dean for the kind words of introduction, and for Robert and his staff for working diligently with me over time to make sure that this day would come. It is truly a pleasure to be home. I have lived more years of my life in the state of Michigan than any other place on earth. 18 of the 22 years I've lived in Michigan have been here, and I have had great pleasure, training opportunities, development right here in this very building where I have spent 18 years of my life. So it's good to be on campus, and it's good to be at ISR, and it's great to be a Wolverine. What I want to do today is to give you an overview. I usually talk about racial inequalities in health and the role of racism and so on. I'll touch briefly on that at the beginning just to give you some context. But I want to focus more on what can we do about these persistent, pervasive challenges that we face, and emphasize that actually there's a lot of science to guide us that we need to put to use. While there are lots of unanswered questions and there's more research to be done, there is, in fact, a lot of science that exists right now. So I'm going to jump right into my talk and look forward to the conversation that we will have at the end. I have a lot of slides to cover. I'll go through some of them very quickly, just in the spirit of time to cover the topics I'd like to today. So, as you all know, but this is just a brief primer on racial inequities in health, large, pervasive, persistent over time. One widely used indicator of health is life expectancy. How long does the average person live at birth? And there is good news in this data, looking at life expectancy for blacks and whites. From 1950 to 2015, there was about an 8-year gap in life expectancy in 1950, and the gap is less than 4 years in 2015, so the gap has been reduced by more than half. That's definitely progress that has been made. At the same time, given the small increases in life expectancy that we have seen in the last 10, 15 years, in fact, the declines for 3 years in a row of life expectancy for both blacks and whites in the United States, that's another topic we can come back to. This gap that exists, if the life expectancy of African Americans increased at the average rate at which life expectancy overall has increased in the last 15 years, it will take 25 to 30 years to close the existing gap. And you could see those kinds of patterns in the data. Look at the life expectancy of whites in 1950, 69.1 years. How long did it take for African Americans to catch up to the health that whites had in 1950? 40 years. 1990 is when blacks achieved the health that whites had in 1950. And another way to think of it, look at life expectancy for African Americans in 2015, 75.1 years. And you could see that back in 1990, whites was at 76.1, were even ahead of where African Americans were. So there are these fairly large gaps. As we look to the future, there's reason for enormous concern. Here's a paper by one of my colleagues, Steve Gortmaker and his colleagues, that looked at national data on obesity in the United States. There are racial ethnic disparities in obesity at age 2 in the United States. And they projected that 57% of all American children who are currently aged 2 to 19 will be obese by age 35. And for African Americans and Latinos, almost 70% will be obese. Of African Americans and Latinos currently aged 2 to 19 will be obese by age 35. And obesity is a big predictor of a broad range of chronic conditions, so that there's reason for concern. I could give you other statistics that give other reasons of concern, but just to give you an example of a reason of concern. When my career started, most researchers thought that the big driver of racial inequities in health were racial differences in socioeconomic status, in income, education, occupational status. And if we combine individuals at the same level of SES, race wouldn't matter. We now know that life is more complicated than that. And here's life expectancy at age 25, for blacks and whites in the United States. There's a 5-year overall gap. Whites at 25 will live 5 years longer than their African American counterparts. If we look within the white population by years of completed education, there's a 6.4-year gap, bigger than the black-white gap, between whites with a college degree and whites who have not finished high school. And within African Americans, there's also a gap, 5.3 years, bigger than the black-white gap again. So the role of socioeconomic status is clearly central as a driver of these inequities we see, irrespective of race and ethnicity. At the same time, there is something profound about race that matters at every level of socioeconomic status. So white high school dropouts still live 3.1 years longer than black high school dropouts, and the gap widens as education increases. It's a 4.2-year gap between the college graduates, and arguably one of the more stunning statistics I will show you this week. And today, remember, this is national data for the United States. The best off African Americans, those with a college degree or more education, have lower life expectancy than whites with similar level education, lower life expectancy than whites with some college education, lower life expectancy than whites who have completed high school. So there's something profound about socioeconomic status that matters for health, but there's something else about race that matters profoundly, and researchers have been trying to understand, could racism be part of the explanation of this phenomenon? So I'll touch on racism briefly. It's important to distinguish between individual discrimination and institutional discrimination, and I want to give you a quick empirical example of both. Researchers at Portland State University ask a simple question. When someone in the great city of Portland stands at a crosswalk intending to cross a street, does your race determine how long it takes before a driver yields for you to cross the street? So they took 3 black males and 3 white males, dressed them similarly, put them at different intersections at random times of the day, demonstrating the same intention to cross the street, and they found that multiple cars were twice as likely to pass a black person waiting to cross the street, and that blacks had to wait longer to cross the street. That's individual discrimination. We're talking about the behaviors of individual drivers as a sort of stimulus of a black person waiting to cross the street. Here's an example of institutional discrimination. This is data from the Cooperative Congressional Election Study, national data for the United States in the 2012 presidential election. How long did people have to wait in a precinct to vote? And it turns out that your race, on average, determined how long you waited to vote. Now, none of that reflected the individual behavior of precinct workers. There was no discrimination on the part of individual precinct workers. Instead, it powerfully reflected where you voted and what were the budgeting and space constraints and the policies and local administrative procedures that determined the size of the precinct and how much staff was there that then determined how long you waited to vote. So while there was no individual discrimination, there was still a dramatic difference in outcome of how long you waited to vote. And institutional discrimination and institutional racism is a driver of racial inequities in health. And I'll just give the example of one that I have studied. Residential segregation is not the only mechanism, but it's certainly a very powerful one. Residential segregation, John Sell, a historian at Duke University, wrote a book about the origins of segregation in the US South and South Africa and argued that segregation was one of the single most successful domestic policies of the 20th century. Beneath the radar screen, but a driver of racial inequities in health. And not just in health, in virtually every domain of life. And you're saying, what does segregation have to do with anything? Well, in the great United States, where you live determines where you go to school and the quality of education you receive. It determines access to job opportunities. It determines quality of neighborhoods and housing. It determines whether it's easy or difficult to live a healthy lifestyle. It determines exposure to nature, toxic exposures, even access to medical care, quality of city services. So a broad range of factors are all patterned by place. Two of America's most eminent sociologists, having studied 171 largest cities in the United States, William Julius Wilson and Robert Sampson, concluded that because of segregation, there's not even one city where whites live in equal conditions to those of blacks, and the worst urban context in which whites reside is considerably better than the average context of black communities. And segregation is a determinant of access to opportunity and therefore is a driver of socioeconomic inequities in health. Socioeconomic, racial differences, socioeconomic inequities didn't just happen. They reflect the impact of segregation. Here's work by David Cutler, a Harvard economist, using national data for the United States, using fancy economic models I cannot even fully describe. But he's able to statistically eliminate the impact of segregation and concludes that if you could eliminate segregation from the United States, you would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. The power of institutional discrimination producing large-scale inequities across the United States. So what are the strategies that we can use given this background? Strategy number one is what I call we need to create communities of opportunity to minimize, neutralize, to dismantle the systems of racism that have created inequities in health. And I want to just quickly give you a few examples of studies. There are many more studies that I don't have time to draw on that suggest that if we try to do this and do it in a comprehensive way, we can have a huge impact. The first thing that a community of opportunity has is a place where people invest in early childhood. And we have examples of the Perry Preschool Study right here from Ypsilanti, Michigan, but I'm focusing today on the Carolina Abecedarian Project in Chapel Hill, North Carolina, which randomized poor kids, most of them African American, at birth through age 5. So it's an early intervention, birth through 5. What did they receive? A safe, nurturing environment, good nutrition, high quality medical care. And by their mid-30s, those who had received the intervention compared to those who didn't have multiple, lower on multiple risk factors of cardiovascular disease and metabolic disease. Give you an example of the systolic blood pressure differences between those who received the intervention and those who didn't. So it's a dramatic effect on multiple risk factors for chronic disease linked to what occurs between birth through 5. A community of opportunity is also a place where we focus on reducing childhood poverty. The sad reality is that the United States ranks near the bottom of the industrialized world on childhood poverty, 34th in this report, child poverty rate in the United States. And child poverty certainly dramatically varies by race. You can see about a third of African American and Native American kids are being raised in poverty, about a quarter of Latino kids, and about 11% of Asian American and white kids. When we think of poverty, it's important to realize although the rates are higher for disadvantaged groups, if we look at the number of poor people in the United States, the largest group of poor people are whites. Then comes Hispanics, then comes blacks, then comes Asian Americans. So the prevalence and the actual number of people are not the same, and it's an important point to keep in mind. This is a chart from UNICEF, and what they are showing here is the child poverty rates in various countries before taxes and transfers. Taxes and transfers reflect the policy preferences of a society. And so, for example, in Ireland, the economic system in Ireland produces a child poverty rate of 42%. But after the taxes and transfers, the policy preferences are indicated, the child poverty rate is reduced to 8%. And you see similar dramatic declines in Hungary or Australia, New Zealand, Canada. In the United States, the child poverty rate before taxes and transfers is 24%, and after taxes and transfers is 23%. So we are literally not making steps to invest in improving outcomes for children that we could. And a community of opportunity has to work to reduce childhood poverty. Communities of opportunity are also places that will enhance income and employment opportunities for youth and adults. There's a lot of scientific evidence. I'll just show you a few studies that show providing disadvantaged households and individuals additional income leads to improvements in health with no health intervention. Here is one study that looked at the impact of increases in the minimum wage on infant mortality. And this study found that every dollar increase in the minimum wage above the federal minimum is associated with a 1% to 2% decrease in low birth weight and a 4% decline in postneonatal mortality. And if all states in 2014 simply increase the minimum wage by $1, there would be 2,790 fewer low birth weight babies and 518 fewer postneonatal deaths per year. So just additional income to a household has positive impacts. Another illustration of this is the Great Smoky Mountain study in North Carolina, where Jane Costello and colleagues were following a cohort of young people. During the course of the study, some of the sample was Native American and white. Native American households receive an exogenous shock of income annually as a result of the opening of a casino. And what the researchers were able to measure this as an intervention, and were able to document that the additional income led to improved mental health for those adolescents while they were adolescents, which continued into adulthood even when they moved out of their primary home. The additional income also led to higher levels of educational attainment among Native Americans and lower incidence of minor criminal offenses, and even the elimination of racial disparities on graduation rates from high school and on minor criminal offenses. So again, additional income leading to improvement on a broad range of outcome. I see Jim House sitting up here. This is a paper that he did with Peter Arno, looking at the impact of the Social Security program and the impact it had on not just the economic well-being of the elderly in the United States, but also on the health of the elderly. And it found that the initial implementation of the Social Security program was associated with mortality declines for the elderly, and every subsequent increase in the level of Social Security benefit was also associated with additional mortality declines for the elderly. So again, evidence, and we have similar findings from old age pension programs in Europe, and there's a lot of other evidence that indicates improved additional income and economic well-being for households. The civil rights movement is an example of that led to improvements in the economic circumstances of African Americans, and that led to a narrowing of the black-white gap in health between 1968 and 1978. Communities of opportunity also need to improve neighborhood and housing conditions. We also have high-quality evidence from randomized controlled trials documenting this. The Yonkers Housing Intervention is one example by occupants of public housing were randomized via lottery to move to better housing. 2 years later, those who moved, no health intervention, just changing their housing, better overall health, less substance abuse, less neighborhood disorder and violence. Movers also reported greater satisfaction with services, and the movers had higher rates of employment and lower rates of welfare use. The Move Into Opportunity program is another example. Again, public housing residents were randomized, and this study found 10 to 15 years later, those who moved lower levels of obesity, lower levels of severe obesity, lower diabetes risk. So again, high quality scientific research documenting improvements in health linked to changing neighborhood environments. I'm a big fan of the purpose-built communities. It's not perfect, but it's doing a lot of great things. It's based in, the first purpose-built site was in East Lake, Atlanta. And what I love about the purpose-built model is instead of doing what often happens in intervention programs, we tackle one social problem, the purpose-built model decides to address all of the challenges faced by disadvantaged communities simultaneously. What is also built into the purpose-built model is that instead of trying to move for people, it tries to say, how can we completely transform the existing neighborhoods where individuals live? And so come with me to East Lake Meadows in 1995, a public housing project with 18% crime rate, 18 times higher than the national crime rate, when 90% of the families who lived in that public housing project were victims of a felony every year. Large drug trade is public housing. 13% of adults were gainfully employed, and the schools were one of the worst performing in the state of Georgia. I had the privilege of visiting the purpose-built community, the villages of East Lake, about 2 years ago. There's been a 90% reduction in violent crime, 73% reduction in crime, high quality privately managed housing. 50% of the residents still qualify for public housing, 50% are at market rate. All adults gainfully employed, eligible to work, and the school is one of the best performing in the state of Georgia, even though 60% of the students still qualify for reduced price lunches. So it's a powerful illustration. The model is being replicated in communities across the United States, and the purpose-built communities will provide free technical assistance to any community in the United States who wants to replicate the model. So we have high quality evidence, we have practical demonstrations that yes, we can transform environments. One of the intriguing things of the purpose-built model, I haven't shown you any health data because they were not health researchers. The director said, I thought I was doing community development. I didn't know I was doing health. So they haven't measured health. Hopefully they can do that at a future purpose-built site. So what I'm saying is the first strategy is to build communities of opportunity. The second strategy is to build more health into the delivery of medical care. And the first principle of putting more health into healthcare is ensuring access to care for all. I want to share with you one dramatic example. Medical care alone will not solve all the problems, but it can make a huge difference for some health conditions. So here's an example, a statewide intervention in the United States. This is the state of Delaware that implemented a comprehensive colorectal cancer screening program, providing free screening for colorectal cancer to everyone whose income was less than 250% of the federal poverty level. Then a couple years later, they added free treatment to everyone in the state of Delaware with incomes up to 6.5 times that of the federal poverty level. So virtually everyone had access to cancer screening and cancer care. They also did, importantly, special outreach efforts to the minority communities to make sure that people were aware and knew how to access the services that were now available. What did we have? Virtually an elimination of disparities in colorectal cancer screening, reflecting increases in screening for both African Americans and whites. We had virtual equalization of the incidence rate of colorectal cancer. And look, that's just between 2001 and 2009. Didn't take a long time to see these fairly dramatic effects, reflecting again declines for both racial groups and a near elimination of mortality, racial differences in mortality for colorectal cancer, again reflecting declines for both racial groups. So it's a dramatic example that by providing comprehensive care with outreach that links individuals to services, we can have a huge impact on some health outcomes. Building more health into the delivery of medical care also means we need to eliminate racial inequities in the receipt of high-quality medical care. The Unequal Treatment Report, published in 2003, documented that across virtually every therapeutic intervention in the United States, from high-tech procedures to the most simple and elementary forms of medical treatment, blacks and other minorities receive poorer quality care than whites. Recent studies document the persistence of these disparities, and they document that implicit bias is one contributor to these inequities in care that exists, that persists in the United States. Are there things we can do about implicit bias? Yes, there's evidence that it can be reduced under certain conditions. Here is a study from the UK that shows one dose of a beta blocker can reduce implicit bias over the next 2 hours. It's high quality, randomized, double-blind, parallel group, placebo-controlled design study shows implicit bias is reduced. One dose of a beta blocker. Now, we don't think that that may be the permanent practical solution to medicate the entire society, although there are days that I wonder whether that might not be a good idea, but I don't think it's practical. There is evidence, though, that there are multiple prejudice-reducing strategies like stereotype replacement, counter-stereotype imaging, individuation, perspective taking, increasing interracial contact, that all have shown in small studies, not with healthcare providers, but typically with students, to have an impact in reducing implicit bias. And I'd like to talk about the Devine solution. Professor Patricia Devine from the University of Wisconsin has shown that you can put all of these strategies into a single program, and that non-blacks can be motivated to increase their awareness of bias, to increase their concerns about the effects of bias, to implement all of these strategies, and that these strategies are effective in producing substantial reductions in explicit and implicit bias that remains evident for 3 months. So, and 3 months may not sound like a long time, but it's the longest that has been shown in a study. Most studies that look at the success of a program measure at the end of the program. So measuring 3 months later and documenting that the effect was sustained is important. So there are strategies that can be implemented. Many observers are saying that even a successful implicit bias program alone is not enough. That it's not just about an individual recognizing their own implicit biases, but understanding that the structures of society have implicit biases built into their policies and procedures, and effectively addressing the societal impact of implicit bias requires that we identify and dismantle its institutional legacies in the ways in which many of our institutions work. Another part of putting more health into the delivery of health care is providing care that addresses the social context and the social challenges in the lives of patients. The World Health Organization asks, what do we accomplish if all we do is to treat illness and send people back to live in the same conditions that made them sick in the first place? So we really need to be asking a new set of questions of how can healthcare providers identify patients' non-medical healthcare needs and connect them to it. How can we connect patients to local services and resources? How can the healthcare sector collaborate with other sectors to improve health? How can we connect community residents to jobs, given that the healthcare sector is a major provider of jobs in many communities? How can we work more with community health workers to maximize the potential impact of healthcare? One example of a program, there are many, that are trying to take a more comprehensive approach is the medical legal partnership that was born at the Boston Medical Center 30 years ago and now exists in multiple communities, including Ann Arbor, if the website is correct. At the Boston Medical Center, where this program was developed in the pediatrics unit, a primary care provider can refer to a number of specialists. One of the specialists is attorneys. The hospital has on-site attorneys to solve problems in the lives of patients. Because if a mother comes with a child with asthma, all the asthma medication in the world will not enable that child to breathe symptom-free if that child goes back to live in the same housing conditions that made the child sick in the first place. And a lawyer intervening can make a difference to improve conditions. Another factor, I'm going to come back to this, building more health into the delivery of medical care means we need to diversify the healthcare workforce so that we can meet the needs of all of our patients. But the third strategy I want to talk about today, which is the most challenging one, we need to raise awareness levels of racial inequities, and importantly, we need to build political will to address them. So the question is, if there is this evidence I've just reviewed, evidence from high quality scientific studies, that we know what to do and that these strategies would work, what are the barriers? What's holding us back? What's the elephant in the room while we haven't made more progress in addressing inequities in health? Well, national public opinion data reveal that large subgroups of Americans see disparities as the fault of minorities themselves. Many are indifferent. Some, I would argue, may even be delusional. So let me give you actual evidence. This is from a study completed in September and October of last year. Large probability sample of more than 5,000 persons. And they were asked the question, blacks would do as well as whites if they only tried harder. All inequities, racial inequities, would be eliminated if blacks only tried harder. 42% of all Americans believe that trying harder would solve them. And that was true of 72% of Republicans and 23% of Democrats. Blacks would do as well if they only tried harder. That was true of 45% of whites overall, and 43% of Latinos, and 24% of African Americans. If we look within whites, there's dramatic variation for some white subgroups. 52% of white males believe that just trying harder would solve the problems, compared to 39% of white women, 51% of whites with less than a college degree, compared to 33% of whites with a college degree. So there's another recently published study that documented that Americans underestimate the degree of racial inequality that persists today, and that this pattern of underestimating is most pronounced among high-income whites and those who believe in a just world, because it's nice to think that the privileges you experience are due to everything being fair and just. And so a lot of Americans are beginning from the point of view where they overestimate the progress that has been made towards economic equality in the United States. So we do need to raise awareness levels of the problem of racial inequities in health. If people don't even perceive that a problem exists, they're certainly not motivated to address it. And national surveys find that more than half of all adults in the United States do not know that there are black-white differences in infant mortality and in life expectancy. Those are the questions that have been asked, and it's been consistent over 20 years. More than half of American adults are unaware. So we do need to think of systematic and sustained attention to identifying the optimal communication strategies to effectively communicate the extent of health inequities and their human, social, and economic costs. And public opinion research over the last 4 decades has shown that the levels of support for government intervention, certainly to help blacks, have been low and even declining over time, is a conclusion of work by Larry Bobo. I'll give you one example of this difference, showing much less support for addressing racial inequities than addressing class-based inequities. This is a national study, split sample design. Half the population was asked, given businesses and industry special tax breaks for locating in poor and high unemployment areas, would you support this? And the other half was asked, given business and industry special tax breaks for locating in largely black areas. So if you give white Americans the cue of class helping the poor, 70% would support those breaks. But if you ask them about helping largely black areas, support falls to 43%. Among African Americans, whether it's a class cue or race cue does not make much difference. So we see dramatic differences in the levels of support for intervention. So we really need to build the science base that will guide us in identifying what framings we would use, how do we build the political will, and we also need to find out how can we tell the story of the challenges of the disadvantaged in ways that resonate with the public. And one of the big barriers we have is what researchers today are calling an empathy gap. This empathy gap was identified in an 1899 publication by W.E.B. Du Bois. The publication was called The Philadelphia Negro. In that book, he had a chapter on Negro health. Towards the end of the chapter of Negro health, after he laid out the inequities, Du Bois continued by saying the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And he says there have been few other cases in the history of civilized peoples where human suffering can be viewed with such peculiar indifference. Researchers today call it the empathy gap, and there's a lot of evidence that there's less empathy for problems that affect blacks than for problems that affect others. Here is a recent review that looked at studies from around the world, and so it's not a uniquely American phenomenon. And these are studies that measure, don't rely. There's lots of studies that rely on self-reported empathy, but these are studies that are monitoring the empathic brain activity when viewing the suffering of another person. And it's comparing the brain activity when you're viewing someone of your own race as suffering versus someone of another race as suffering. And these studies document a racial in-group bias is consistently found in brain injury in studies in Europe, Africa, Asia, and the United States. So it's a fairly universal phenomenon. There's stronger empathic neural response to the pain of someone who you identify as your own race as someone from another race. What are the predictors of this racial gap in empathy? It's more pronounced among persons who are high in implicit bias, among persons from cultures that are more collectivistic and than individualistic, when individuals who were exposed to harsh living conditions. In fact, studies also find that the experimental administration of oxytocin, which should reduce the implicit, this tendency to have this gap in empathy, works if the person is of your same race, but oxytocin does not work if the person is of a different race. So this is a fundamental problem that exists, and when there isn't empathy, there is no commitment to policy action. Here is one study that shows this empathy gap becomes evident very early in life. It's a study of mainly whites, 5, 7, and 10 years old. They rate the pain of a black and white person. They see the picture of a person being stuck in the arm with a needle. There is no racial bias at age 5. At age 7, there's the tendency for the kids to see that the white person is experiencing more pain than the black person. By age 10, it is pronounced. So efforts to address this racial empathy gap really need to begin very early in life, because there's something profound about socialization in this society that leads these policies, this difference, to be evident early. And there's a lot of evidence, I don't have time to go through it, that document this prejudice, this racial prejudice drives policy profoundly. Here's an example of one study that found there was a lot less support for Obamacare, 20-point difference in national data, percentage point difference, than there was for the Clinton healthcare plan. And that difference in level of support can be accounted for by racial prejudice. So part of the reason for the opposition to Obamacare is driven by racial prejudice. This is a plain, simple way to state it. What reduces this gap in empathic brain activity? This review of the research finds that when individuals are instructed to focus on a person's suffering, on the suffering of the individual, it's individuation. It's also a strategy that was mentioned earlier with regard to implicit bias, instead of on the racial background. So an explicit instruction tended to reduce the gap. When individuals are on the same team with members of a racial outgroup, that's tended to reduce it, and greater experiences of interracial interaction in the early life and socialization of an individual also tends to reduce it. What this says to me is that major investments in research are needed to identify how we can best close the empathy gap in real-world contexts, and to expeditiously bring to scale interventions proven to be effective to address this. All of these challenges of addressing the empathy gap and addressing the prejudice is also becoming more difficult in the current political environment within which we live. Racial attitudes and values that have been deep-seated but dormant have now surfaced and are flourishing in ways that are driving policies and politics. There is increased salience and visibility of incidents of racial prejudice and discrimination. In fact, there is considerable scientific evidence, and I'll just go over this really quickly, that indicates that the current political administration we have has been driven by racial prejudice. Growing evidence that racial prejudice and racial resentment and immigrant resentment is the dominant contributor to the support of Donald Trump. One study found that after adjusting for a broad range of other factors, whites who strongly agreed with the statement that they were afraid of people of other races were 10 times more likely to have voted for Trump compared to those who disagreed. Another study found that simply reminding white Americans who scored high in a measure of racial identification that whites would become a minority of the population in 2042 led them to be more concerned about the declining power of whites, led them to increase their support for candidate Trump and for anti-immigrant policies. Another study found there's a lot of interest that no, it's not prejudice, it is economic factors. And this study found that as respondents moved from a high level of acknowledgement of racism to a denial of racism, there was a 60-point increase in support for Trump. There was similarly a 20 percentage point increase as someone moved from non-sexist views to sexist ones. So sexism also plays a role in these robust associations. Here's another study, denial of racism, the same study, sorry, more strongly predicted voting patterns in 2016 and in 2012, and predicted voters who voted for Obama in 2012, but became Trump supporters in 2016. So there's a lot of evidence, and this is just a handful of the studies that show the power of underlying racial prejudice in the challenges that we face currently. There's good news. Here is a relatively recent study published in Science suggesting randomized controlled trial that there may be ways in which we could dramatically reduce prejudice. This study focused on transgender individuals and showed that prejudice against transgender individuals could be reduced within a 10-minute non-confrontational conversation. In this intervention, 56 canvassers went door to door, encouraging 501 voters to take the perspective of a transgender individual. In the script that they all followed, the voter did most of the talking. It wasn't the canvasser trying to persuade them. But the goal of the canvasser was to enable the voter to recall a time in their own life when they had been treated negatively, so that they would understand the perspective and develop empathy. We come back to empathy with the challenges faced by a transgender person. Voters in the control group had a conversation or the canvasser about recycling. So what did the study find? The study found that this intervention led to substantial reductions in prejudice against transgender people. It led to increases in support for a law that would protect transgender individuals from discrimination. The changes were evident irrespective of party identification. The changes were evident irrespective of whether the canvasser was transgender or not. And the effects were still evident 3 months after the intervention. This is a fairly striking study, and it illustrates that there may be simple interventions that we could implement and that could have a huge impact. Importantly, to come up with this effective conversation that worked, over 13,000 canvassing conversations were tested, suggesting that there is a lot of work that needs to be done in trying to identify the communication strategies that are likely to be most effective. I also want to point out quickly as I wind down that we also need to think of what we can do to dismantle cultural racism more generally that gives rise to all of these ills, and we need to think of how we can even use the media more effectively as a tool to reduce cultural racism. We also need to think of what we can do to enhance individual and community capacity so that residents and affected populations can be empowered, they and their institutions, to be more engaged in addressing those solutions. There's a body of research suggesting that if we can work with disadvantaged populations, for example, and explicitly build racial pride, because individuals are growing up in the same culture and are being bombarded by the same negative images, and that simply building racial pride can have dramatic, powerful effects. There's a study looked at the impact of building racial pride into a comprehensive intervention and found dramatic effects in terms of reducing recidivism rates, leading to greater likelihood of attending school and finding work, and reduced odds of substance use. So enhancing individual and community capacity encourages us to look at ways in which we can strengthen both the individual and social capacity of individuals. Another intervention about racial pride and reducing HIV risk. The last point I want to mention quickly is we also need to identify, train, support, and mentor the next generation of leaders who will step up to the plate to play a role. And we have to realize that many of the strategies we've implemented have not been as successful as we'd like to think. So how well did affirmative action in medicine work for women and minorities? Dramatic impact on women. Women were 6.9% of graduates from medical school in 1965, 48% in 2010. Minorities, for blacks and Latinos, have moved from around 2 to 3% to 6%. So much smaller success. What has been responsible for these differences? I would argue the differences is women were prepared to walk through the doors of opportunity when they are open, and we need to give much more attention to the pipeline and how we prepare individuals to take advantage of the doors of opportunity. This is stunning. This is in medicine. American Association of Medical Colleges. In 2014, there were fewer African American males in the first year of medical school than there had been in 1978. So we haven't made as much progress as we think. And in the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2012, 3.8% of all practicing physicians are black. So there's a lot needs to be done, not just in the area of medicine, but in virtually every area of activity that we can train and develop the pipeline. I am standing here because of the investments of others who invested in me. I see Jim House sitting on the second row. He was my mentor in graduate school and beyond. And James Jackson, another giant in this institution, was also a very effective mentor for me when I came back to the University of Michigan. And we need to think strategically as individuals and as institutions. What are we going to do to build the pipeline? I leave you with the words of Plato: there is nothing so unfair as the equal treatment of unequal people. There are dramatic inequities, and if we treat everyone the same, we will just reinforce and sustain the inequities. Martin Luther King said, it may well be that we, this generation, will have to repent, not merely for the vitriolic words and the violent actions of the bad people. We wouldn't do what happened in New Zealand this weekend, but for the appalling silence and indifference of the good people. He also said that true compassion is more than flinging a coin to a beggar, but understands that an edifice which produces beggars needs restructuring. There are many edifices that produce inequalities and inequities in our society today. We need to work together to restructure them. Thank you. I think there's an opportunity for those who have brief questions to raise your hand. There is a mic in the room. They'll come to you. If anyone has a question or comment. I see one hand right here to the left.
Hi, thank you very much. That was wonderful. I'm not sure whether you have the answer to this, but the purpose-built community.
Yes.
Do you know a little bit about what was done to make that happen? What kinds of changes occurred? Did they rebuild all the housing? And then how it was funded? I say it's not fair because there's a lot of detail.
Sure. I can give you a high-level overview. There's a wonderful description in a book published by the Federal Reserve Board. Somebody knows the title, Programs at Work, or something like that. And there's a chapter on purpose-built, and there are videos that tell the story of purpose-built, if you go to YouTube, and so on. So there's a lot out there on it. Basically, though, what the purpose-built model, the success of the purpose-built model reflected the cooperation of the Atlanta Public Housing Department with a wealthy philanthropist who built many of Atlanta's skyscrapers, and community leaders from that community itself, mainly a group of older women who were very active in the community. What happened? They came together and envisioned what it could look like. It all was triggered by the wealthy philanthropist who was interested in purchasing a golf course that was next door. And he drove through the public housing project and was shocked to see the conditions in which people were living in the United States, and said, what would his life be if he had grown up in that environment? And was motivated to say, we have to make a difference. So it did take private investment, and the purpose-built model requires a community that wants to replicate their model to identify local resources and potential individuals that could come to the table with significant philanthropic dollars. But it heavily focuses on community involvement, tearing down the existing infrastructure, building a new infrastructure, a commitment to 50% being at market rate, and 50% being qualifying for public housing, so that you have the mixed income model, and committed to high quality education from cradle to high school completion. One of the points I would say that they mentioned is that they are able to operate their early childhood program, their elementary school, and their high school strictly on the basis of public dollars. So the ongoing operation is strictly on available public dollars. However, to get it started, they need the philanthropic support. I see a hand all the way at, okay.
Hi, thank you so much for your presentation. My question is about, knowing what we know about gentrification, you talked a little bit about the segregation, and we see that some of our communities are being diversified to other communities, and we also know about the negative impacts of gentrification. Can you speak more to about like nuanced strategies about what would you say about combating segregation in this particular climate?
So let me go back to the purpose-built model again. The purpose-built leadership actually bought out surrounding territory, property, as a strategy to limit gentrification. But they said to me, we should have bought more. Because gentrification is taking place. They control some of the neighboring property, they can expand and they can maintain their model, but the dramatic transformation in that area has dramatically transformed the area of surrounding communities. And so there is some gentrification taking place, and they said they didn't think hard enough. They should have bought more property, because at that point it was relatively inexpensive, and they did think about it, but it didn't do enough to limit its impact. I think across the country there are multiple models that are being used to try to limit gentrification and try to ensure with new construction there is units are reserved for low-income individuals. I think in most cases it's too little too late, and not the real kind of major commitment that needs to exist to ensure that there is affordable housing for most. So I think gentrification remains an ongoing challenge. There are organizations, like I'm thinking the one in Oakland, California, just gone from me, Angela Glover Blackwell led it. Policy Link, thank you, that has some resources on the topic of gentrification that might be helpful. Yes.
Hi, I'd like to revisit a concept. I'm not sure if it's being debated anymore. The term, the phrase race. It seems to me that the social sciences have capitulated to the concept, whatever it represents, and its usage in general, in all our vocabulary applications. Is there any debate about that term anymore, and what it represents in terms of exclusiveness, inclusiveness, what it leads to in terms of all of the ramifications of our conception of different people from different places and different cultures?
It's a great question. I'm not sure there's a simple answer. There has been debates, I think both, by the way, on the political right and the political left, about arguments that we should abandon collecting data by race. And there are societies that have done that. In France, it's illegal to collect data on race. As a researcher, as a government, you can't collect data on race in France. That has not eliminated racial inequities in France. They still exist. The prison population in France is heavily made up of certain subgroups and not of others. So the question becomes, race is part of our vocabulary. I think where there has been greater emphasis in the scientific literature is being clearer on what we use race to mean. And it is still true studies in medicine that there is a bias to think of race as capturing biological distinctiveness within human population groups, while the evidence suggests that race is primarily a social category and not capturing biological distinctiveness. So I think that's where the debate is. In the US context, we still have OMB Directive 15, which forces every US statistical agency to collect and report data by race. So I think it's an important issue, but I think the challenge is to educate our population of what race is and what race isn't. There are some medical journals, including, I think, JAMA, that had a statement of, if you use race, here are criteria that you need to use and provide a rationale for why it is being used and what you're using it to mean and so on. And those are good steps in that direction. I see Jim Marx's hand over here.
Thank you. It was a great talk. Couple of points. First of all, it's the San Francisco Federal Reserve Bank. Go to their website, and the book that you mentioned and several others that talk about community development. Community development is one of the roles of affordable housing and all of that of the Federal Reserve, and it's there that the purpose-built community information is included. And I think the person's name was Trammell Crow. And if you watch golf on TV, there is now a tournament at that golf club, and the charitable purpose is support for the East Lake area. I was thinking about what's the future structural racism issues that we have to pay attention to. And I wondered if you thought about the implications of artificial intelligence and the algorithms that are going to drive that. They won't be as public as we see in public policy, but they'll be perhaps even more influential.
Thanks, Jim. I haven't thought deeply about the role of artificial intelligence. That is true. I think we still have the current legacies of segregation. We still have a prison industrial system. We still have immigration policy. Those are the other examples that I think most frequently written about in the public health literature, but you're right. I mean, I think of other technological developments and the potential. I think this is not structural racism, but many are concerned about even our focus on precision medicine, and that is very individualistic focus. I'm not opposed to it per se, but we do need to think of how we balance our investment of resources, and we certainly need to think of how we combine addressing many of the fundamental structural drivers of inequities. And given the fact that disadvantaged populations have lower levels of access to the best medical care now, is precision medicine only going to widen that gap, where the haves will have precision medicine and the have-nots will be left without it. So, I mean, I think there are lots of storm clouds on the horizon that we can be concerned about. Yes. I see a hand here and then one in the back.
Thank you so much for giving some ideas about strategies that we can put into action. And I'm just wondering if you can offer any not strategies, but words of encouragement or methods for advocating to kind of implement some of these things locally at universities.
I don't know that I have any unique suggestions beyond that which I just talked about. I do think that within public health and other disciplines that are focused on inequities, we really need to pay a lot more attention to communication and communication strategies, and we can test and identify what kinds of messages resonate and what kinds of messages are effective in building empathy and in building emotional connection. Research that Tom Pettigrew did in Europe found studies in England, in France, in the Netherlands, in Germany, looking at an immigrant outgroup in each of those societies, that one of the strongest predictors of policy preferences was not what they thought about the group, but how they felt about the group. Those two questions, how often you feel sympathy and how often you feel admiration, coded together as a high, no positive affect for the population, was one of the strongest predictors of policy preferences. And James Jackson and others replicated that in the Detroit area study, asking whites from Wayne, Oakland, and Macomb County how often you feel sympathy for blacks and how often you feel admiration of blacks. And no positive affect for blacks was the single strongest predictor of whites' opposition to government funding to assist blacks and whites' opposition to affirmative action and employment. And we tested political party ID preferences, income, liberal, conservative, traditional prejudice, social dominance orientation, beliefs of the nature of inequality in American society. The driver, the Ann Arbor News headline was "Prejudice Drives Policy," actually about that study, that it's tell me about how you feel about a group, and that will predict your commitment to invest in helping that group. So I do think that's what we need to do, and the model of that study from science about looking at canvases, but remember, they tested 13,000 scripts before they found the right one that was effective in working. And I just think we need to pay a lot more attention to that. I think the American public generally we are a generous people, but we only are willing to invest in those who are worthy. And the work of Frameworks Institutes indicates that there are dominant frameworks that the average American has about race that leads them to exclude many persons of racial ethnic backgrounds as not worthy because they're not deserving of help because they have brought the problems upon themselves, their failure to practice normal American values. And I would say go to the Frameworks Institute's website. They have a wonderful issue brief on how we talk about race and racial disparities that's helpful. Again, I think the message of the 13,000 tests suggests that maybe some of the things they tested didn't work, can work in an alternative form. And I do think that's a major area of research that we focus on. How can we build empathy? How can we tell stories in a way that connects so that we can change the emotional connection that many have to the challenges we are talking about so that we can shape policy in a different direction?
I think that drives the question in from a devil's advocate perspective around whether a more universal thought might appeal more to folks if you were to say that within their group. So you showed, for example, if we could think about, for example, low-income white folks who have life disparities or anything that we can say about within group, your folks have this type of problem, we would like to benefit them. Can we think about this neighborhood or this policy that can impact the greatest number of people within your community, which would then impact, generally speaking, as many people that could benefit from that policy? Would that, in your estimation, is that something that would be easier than changing the empathy of billions of people? And again, this is devil's advocate, for me. But.
Yeah, but empathy can be changed. I mean, so we know that empathy can be changed. But I mean, if you look at some of the work in psychology, I mean, sometimes there's slight changes of wording that changes whether there's an empathic response or not. So I would say, in answer to your question specifically, some of the frameworks Institute's work suggest that focusing on inequities across communities and not individuals might sell better than focusing on individuals. I just think there's a lot we need to learn and invest. So I think that health disparities researchers need to be working a lot more with communication experts and communication researchers and with political scientists, which is not how we normally think. But I think there's a lot we can learn from them to try to develop the strategies that we need.
First of all, thank you so much for your insightful, inspiring presentation. I've been thinking about kind of the community improvement engagement model, and you mentioned early education is a really important factor in that, but I was wondering if you had any insights on higher education and access to that as well, because I'm researching a lot of college promise programs right now, and looking at them, there's a lot of different models that can kind of affect the effectiveness of them. So do you have any insight on how to make those equitable and make the kind of the best outcomes?
You are the final questioner today. That's we out of time. So let me just say that when I talked about the need for pipeline programs, that's what I'm talking about, that we invest from early on in life, and we look not just at to cream the crop of those minorities who are successful, but we think now of what we can do to improve the quality of opportunity for those minorities today. Let me end with 2 points. The first one I would make is to make the case that I sometimes like to remind folks that in 2016, the majority of persons receiving Social Security in the United States will be white. For every person receiving Social Security, only 2 persons will be paying into the Social Security system. One of those 2 will be Black or Latino. They are now in kindergarten. If we want a system of support that will be there for us in our retirement, we need to think it's in our strategic best interest to do everything we can to ensure that those Black, Latino, and Native American kids today get the best quality education so they have the skills to be productive, tax-paying workers in the workforce so that our retirement will be secure. So it's in all of our interests. And the final point I would make is on the point of what we do. I would like to end on the point I made in my TED Talk. I am an affirmative action baby. Without a minority fellowship from the University of Michigan, I would not be standing here. And we need to think of what we can do to open doors of opportunity even earlier so that all of America's children can experience the promise that American society offers. Thank you.
So now I'd like to introduce our panel. First, I'd like to introduce, and I'll do this in reverse alphabetical order, because that rarely happens. So first, I'd like to introduce Dr. Daphne Watkins. And Dr. Watkins is an associate professor here at the School of Social Work, also affiliated with the Department of Psychiatry and Program Research for Black Americans here at the Institute of Social Research. And again, I'm going to introduce all the panelists right now. Next, I'd like to introduce Vincent Tilford. Vincent is the CEO of the Hannon Foundation. It is downtown Detroit, right, very close to the Detroit Institute of Arts. And if you haven't visited them yet, I really suggest that you may want to consider that at some point in time. It is truly a remarkable organization, a collective organization devoted to the health and well-being of African American elders. And lastly, I'd like to introduce Dr. Brianna Messick. Dr. Messick is a associate professor here in the School of Public Health, Department of Epidemiology, also a faculty member with the Program for Research for Black Americans, and her work looks at the intersection of mental and physical health. So again, please welcome our panel.
You want to start? I can start, sure. Okay. Since we're going in reverse order. Okay, hi everyone. Great to be here. Thank you, Dr. Williams, for giving us something to prompt our thinking this afternoon. And I'm convinced that good luck is brought to me whenever I take a picture with David Williams. I actually took a picture with him in 2005. I don't know if folks can hear me in the back, but I took a picture next to him in 2005 at the MD Anderson Cancer Center in Houston, Texas. And a few months later, I was here at Michigan as a postdoc. And so many of you witnessed the photo I just took over there. So let's see where I am in about 10 years. Okay? But I was really happy to hear Dr. Williams speak to the importance of considering social context in health conditions or of health conditions. I think the social construct of gender is something that he alluded to when he referenced the transgender study. And so I wanted to just give a couple of takeaway points that I had thinking about the social context of gender. So for those who don't know, my work up until this point has focused primarily on studying men, well, I say the 3 M's, men, masculinity, and mood. And so I was really inspired by a lot of the information he provided, and here were some things that I took away from his talk. So these are sort of suggestions, I think. That's how we'll couch this. So the first is don't forget about gender and sex. And the importance of gender norms and roles in families and communities are often overlooked. And I think that while there are some important things to consider with biological factors around sex, I think sometimes we forget about the social construct of gender and how much that influences health inequities. Many of us in the room know that gender is not a binary construct anymore. We understand that there are fluid definitions of gender, and so I was just thinking to myself that the way that we expand how we measure gender will definitely be a way to considering how we can reduce racial inequities in health moving forward. Also, there are some individual identities in the context of gender that I wanted to just note here. This is based on gender socialization. As many of us know, we're socialized to be men and women, starting out from being little girls and boys, but that evolves over time, and that evolution is often not measured. A lot of times cross-sectional data can capture that kind of information, but I think longitudinal data is probably a much better measure, a much better way to see how has someone's socialization to how they identify as a gender entity, how has that evolved over time. So I think individual identities are important, but also the individual's role in their family. And many of our colleagues actually in this room, Robert Taylor, Linda, Chatters, have studied the presence of social support. But I also think that expanding on that work to consider not just support, but the power of the collective is definitely a step, a logical step in the right direction in understanding research on inequities. So just 2 more points I'll make really quickly is I don't want to forget about qualitative data. Survey data is so very important in much of the work that we do here at ISR, here at the University of Michigan, but I do believe that there is some value and some strength if we can amplify the voices behind the numbers. I don't want to forget the voices of the communities that we tend to care the most about, and those communities that have been marginalized for so very long. Oftentimes, some of the most important aspects of what's happening in their lives is not amplified in the numbers, and so we definitely need to think about the voices. especially if we really desire to understand health inequities in the context of gender, I just want to also think about the creative ways that we're able to capture qualitative data nowadays. There's lots of big data around social media, Twitter, Instagram, and such. And so sometimes we often forget about the cultural context of the way communities communicate and assume that focus groups are going to apply very successfully or very well across several communities, and oftentimes that's not always the case. Because my work tends to be on boys and men, oftentimes they don't feel comfortable disclosing weaknesses or fear or struggles that they're having face to face. So I've been able to take advantage of the anonymity that happens behind a computer screen or behind a cell phone app, for example, to really get them to open up about some of the challenges that they're having with regard to health. And then the last thing I'll say, and this is definitely a nod to those of us in the room who do interventions and actually really want to focus on trying to impact the communities in those ways, that we have to think more deeply about how we want to tailor and target our programs based on gender or in the context of gender. Male and female adherence to gender norms are real. We oftentimes don't really pay a lot of attention to just how we were raised. This is just how I am. This is just what I was taught. But I think if we think about the different roles that men and women have in their communities and how they were socialized to do that, I think the way we tailor our interventions to those norms will be very important. We cannot make assumptions about gender, not anymore, not in this day and age. This is definitely a more progressive society where multiple definitions of gender exist. So if our goal is to reduce racial inequities in health, I just wanted to put on everyone's radar, if you have not thought about it, that we absolutely, positively have to consider the context of gender. Thank you.
Well, good afternoon, everyone. I got some great news for you today. I had prepared a 20-minute speech, and so now, based on the comments, I've really cut it down a lot. As already has been stated, I'm with the Luella Hannon Memorial Foundation. It's a 94-year-old operating foundation, and what that means is that we fund our own programs and we serve older adults. In the United States, there are 111,000 roughly foundations, and only 6 focuses on older adults. So I'm really interested in this sort of intersection of age, ageism, and race. And we see a lot of that in our work as well. So just real quick in terms of the programs that we provide, we have social work services that try to help older adults to age in place, to make transitions back into the neighborhood when they've been in the hospital. We have what we call our creative aging program, so that those older adults that have agency and can make it to our facility, they're able to aspire to be artists, and we provide them very rigorous arts training there. But where I see a lot of our work is with our emergency fund. Our emergency fund is usually a fund of last resort for older adults who have nowhere else to go. Just some real quick statistics about Detroit. The longevity in Detroit, when you compare it to the surrounding communities, is about 16 years less. It's called Dying Before Their Time. The Detroit Area Agency did a report several years ago. And if you look at the zip code where I work in 48201, which is the Midtown downtown area. The longevity for seniors in that zip code, and we have a lot of senior apartment buildings around us. Thank you.
I don't think we can hear you.
Oh, I'm sorry. Okay. I thought you were handing me water for some reason. But so the longevity for the people in that zip code is 69 years. So that's worse than what you'd find in Russia and North Korea. And the profile of people that we see in our emergency funds program, almost all of them live alone. They have incomes of less than $1,000 a month. Most of them have comorbidities as well. And the types of things that they come in and they ask us for, either they're coming out of a homeless situation, or they're, they've had a fire, someone's stolen money from them. So they're coming to us to get money for rent or money for utilities. A big issue in Detroit is bed bugs. And so if they're living in a senior apartment building, and they have found to have bed bugs, they have to throw out all their furniture. And we have people with comorbidities who sleep on the floor for a long time before they're able to get to us and get resources so they can have furniture there. So those are the kinds of folks that we do see a lot of in Detroit. And so what I wanted to do, though, was to put an age lens on Dr. Williams' presentation there. Starting first with creating communities of opportunities. There's sort of another motto out there that's called age-friendly communities. Age-friendly communities is being pushed by AARP and the World Health Organization. And one of the things that it does is that it looks at social determinants, but it looks at it across several domains, about 8 different domains there. And by putting an age lens on it, what it does is that any of the interventions that you're doing to improve communities, it needs to work for someone who's 2 years old as well as someone who's 92 years old. And so that's one of the sort of the beauty about age-friendly communities. The other thing, too, is that age-friendly communities recognizes the value in having diverse ages within a community. One of the things in terms of the domains they talk about is, I'm going to put these back on here, is respect, social inclusion, and civic participation. So those are actually 3 different domains there. How many of you have heard of blue zones? A few of you have heard of blue zones. So blue zones are these areas around the world, there are not a lot of them, where the people there live to age 100 at a rate that's several times what you find in this country. And they tried to sort of distill what the lessons were from the blue zones. And some of the things they found was that, yeah, genetics plays a little bit of it, and certainly diet matters as well. But if you look at sort of the 8 or 9 lessons that come out of that, a lot of the things that they talk about is how the older person there in those communities, they don't lose equity over time, they gain equity. They're revered, they're included, they're part of the community as well. So one of the things I like about age-friendly communities is that it has this sort of social connectedness piece that's in there. Improving neighborhood and housing conditions. The city of Detroit was built for 2 million people. It now has less than 700,000, and they're spread out over 140 square miles. For a lot of older people, and this is sort of why I got into this, because I did a lot of work in community and economic development, but one of the things that I saw was that when we were working some of the most distressed communities, we were building houses there, but there were older people there who had a lot of deferred maintenance, and the house is falling down around them, and they have all these other issues going on, and they can't afford to move. They can't afford to go into a new home or whatever, because the home they pay for, no matter what that condition is, it's paid for. So they don't want to move. And so when we start talking about improving neighborhoods and housing conditions for folks, like there's some other things I think we can also do in that regard. EMS in Detroit is overburdened, and they've been really have gotten better over time. But older adults in the community, when they don't have access to public transportation, they don't have access to a car, what ends up happening is if they have to go to the doctor, they call EMS. And so they become super utilizers of the system. So if we're able to sort of solve this, just that one problem, it's just not solving it for older adults, you're also solving it for those people who really need it for emergencies. And if we're able to address some of the older adult issues through, say, some of the social work services going out and connecting the resources, that's one of the ways that we can help. And I know I'm running out of time here, but I was so glad to hear you mention the Frameworks Institute. The Frameworks Institute has also done some work around ageism, so very, very similar in a lot of ways. And so one of the things they tell you in the Frameworks Institute is, don't ever talk about racism, ageism in the same sentence, right? So I'm already violating that one, right? But one of the things they talk about in the Frameworks Institute is that people in general, all of us, we blame old people for the predicament that they're in, right? And for those of us who are old, we otherize old people, right? So in other words, yeah, I may fit that category from an age standpoint, but I'm really talking about someone else. So it becomes that sort of personal responsibility of the reason why you're in the condition you're in is because you didn't say or you didn't do the right things along the way. And so what ends up happening, and I'm going to close with this, but what ends up happening is that I think when you intersect ageism with racism and sexism, that that person becomes absolutely invisible. It makes them susceptible to elder abuse because of just the stereotypes and other ideas that people have that make them think that this is prey for them. I was, and I thought about your point too about the voting precincts and the long lines that were there. And as I think about that, I think, in Detroit, probably older people vote in the highest concentration. And that happened in Detroit where people had to wait out for hours. So again, remember I was saying people with comorbidities and oxygen tanks and things, and they're waiting out there, and they get disenfranchised and they become more invisible as well. So I think that's it. It's all I really wanted to cover in terms of some of the points that you made, but really appreciate being here.
Good afternoon. Hello. Good afternoon. My name is Brianna Mezek. I'm the co-director of the Center for Social Epidemiology and Population Health here in the Department of Epidemiology at the School of Public Health. And it's a pleasure and an honor to be on this panel and to be commenting on Dr. Williams' lecture today. I wanted to there was so much to take in, and I guess I think I wanted to focus my comments on the sort of takeaways in terms of the strategies and the idea of the action orientation that Dr. Williams brought us today. The first is this idea of health in all policies, which is an idea that foundations like the like the Robert Wood Johnson Foundation and others have really pushed for. The example of the purpose-built communities, they were doing community development, they weren't doing health policy, but perhaps if we can have that broader idea around we should always be measuring health and we should always be thinking about health in all policies, that may help us better understand the true impact of these kind of more social or economic policies. I think on the flip side too, it's probably important to have money in all policies so we can see the actual dollar amount that health disparities cost, and that when we only talk about health as an outcome, we are missing the other flip side of it is the money, and you make this point very well with the argument around Social Security, for example. The second point I wanted to make was sort of reflecting on the idea of being able, that people are able to take advantage of opportunities when those doors open. And this, I guess this comment is mostly focused on, or mostly oriented to the students in the room. And my comment on this is to keep pushing those doors open. I can't tell you how many award committee things I've served on, but I'm always struck by the small number of candidates. I don't mean that in terms of that they're not qualified when they get it, but just I think about all the people who didn't even bother putting their name in the hat because there was no way they could possibly, they'd already decided they weren't qualified. And so then I literally, I'm telling you, we've had flipped a coin in meetings to assign awards because we had two equally qualified candidates. And what were we going to, and the idea that that award might then be the signal on somebody's CV that gets them the job interview, and it was literally decided by a coin flip, is insane to me. But that is the law of these, sort of law of small effects and cumulative advantages and disadvantages. So my reflection on here is to keep pushing doors open. My third point, or my third comment was on this idea of, I guess this broader thing that we're going to be struggling with for a long time. This idea about when do we educate and how do we educate people about the true nature of reality? I have a colleague who's done a lot of work in energy efficiency, and she was telling me that one of the things that they do is they give like energy report cards, and they sort of say, like, you use a lot more energy than your neighbors do, and that they've done experiments, and like that actually reduces people's energy use if you find out that like you're the outlier. And I wonder if something like that, some sort of like here's your I don't know what this would actually look like, but that something that really puts people in context and makes it real for them. Because I think that one of the things that contributes to the delusion, essentially, as Dr. William puts it, is this idea that people don't have access to, or they don't understand that there are like damn lies, and statistics out there, and that those numbers are the source of information may not be reliable. So I wonder if something like that, the types of things that have been used for energy efficiency and improving energy efficiency that do change behavior, could also be applied in this context in some way. The next thing I was reflecting on was the idea around implicit bias, and we have a study right now that's being done in Virginia that is trying to recruit, this is around the framing of the issue and messaging. Like, how do we get people kind of on board with this idea of addressing implicit bias? So we're funded by NIDDK to video record racially discordant patient-provider interactions, and our goal is to understand how physician implicit bias relates to African-American patients' satisfaction and perceived sort of relationships with their doctors. It is very difficult to recruit for lots of different studies. It is extraordinarily difficult to recruit physicians for this study. And so this study is called the Building Positive Patient-Provider Communications. Like, that's what this study is called. And we were literally just turned down from another clinic, internal IRB, which is already approved by the Institutional Review Board, and there is no scientific reason for the rejection of this effort. Sometimes it's just being blatantly said, like, we don't want to be part of something that will show that our doctors are racist. And so it's the corollary, which is that you have racist doctors. Would you like to do something about that? Is actually not, and like that's not part of the conversation. And so I'm very, and this is just an N of one, like that's an anecdote, but I do think that there's, this framing is something that whether it's we need more training, we need more partners, yes to all of that, but there's a real difficulty there. The other thing I wanted to comment on is I think that the thing I'm taking away from this is the importance of being politically active. And I think that can mean lots of different things. So even it sounds like I need to run for school board, because it sounds like the type of interventions that we're talking about in terms of exposure, these need to happen at a very early age, and so now I need to be, so I mean, I think that when we hear being politically active, or at least when I hear being politically active as somebody who's not necessarily grown up in with that being a norm, it can be very intimidating as to like what that means. And I think that there are lots of great examples. I do some consulting work with an organization called the National Association for Urban Debate Leagues that brings debate programs into cities around the United States, and many of the alumni of that program are very politically active, and it's really inspiring to see the work that they're doing. The last comment I wanted to make was I'm reflecting on the finding of the study of the men crossing the street. And that really bothers me. I mean, I'm not bothered by the fact that it was done, but like that was the thing that for me like really just sits. It just sits deep in me, and and it kind of emphasized a couple of different things. And maybe this is too much of a downer, but it emphasized to me that like feelings trump facts, and it's not like they trump facts like a little bit, but they really, really, really trump facts, and that there's not going to be, there's never going to be like the combination of data that then convinces someone to slow down and not like aggressively, like, you know, turn the car, you know, in front of somebody's path when they're walking in the street. And so I guess I don't know what to do with that. That's the thing that I'm struggling about, or that I'll be thinking about the most after this talk. I think that one of the, I guess the other question that sort of relates to that is that if we are to address this empathy gap, it's not just, I think, the content of it, which I think is obviously very important, this idea that you needed to test out, you know, 13,000 messages before you got a p-value of less than 0.05 is shocking, you know, but it's I don't mean it in that way, but just the idea that, like, it's there, you know, these little things make a difference. But beyond the content, I think there's this issue of setting. Where does that messaging occur? Timing, when does that messaging occur? How frequently does that messaging occur? And then by whom? And those are the pieces that I'm most, I think that if we can kind of make some headway there, and it sounds like a lot of this needs to happen in partnerships, whether with other disciplines, but then also with organizations that are in these communities, I think that's probably the best way forward. Thank you. Yeah, I know.
So you moderate.
Yes.
And let me just mention, we have some time for question and answer for both, for the three members of the panel as well as Dr. Williams.
Should we switch?
So you just raise your hand and we have people with microphones walking around.
Hello, this question is for Mr. Tilford. So I am a first-year doctoral student, and I study aging and race as well. And I was just wondering why people have said not to mention ageism and racism in the same context, as, like you said, there's a lot of overlap. So just curious.
So the frameworks, and this is good. Okay, so the Frameworks Institute, I guess, did a very similar type of research project that they did around racism. And so when they went out and they polled people about this, some of the feedback that they received was that you're equating ageism with racism and sexism, and we know those two things exist, right? But for ageism, you know, we're taught from very early on to fear getting older. And as a result of that, you know, no one ever challenged us on ageism. You're never ever challenged on that. So despite sort of, you know, kind of where we are around racism and sexism, you know, and people still doing whatever they want to do, I mean, they know that there's something wrong with it, don't they? But for ageism, no one knows this. I mean, my kids make age jokes about me all the time, and I try to correct them on this, like, that's not proper, right? But you know, you think about it, you know, you have these sort of microaggressions on ageism throughout your entire life. And then what ends up happening is that you end up believing it yourself, and it perpetuates in your own life as well. So that's what I think the reason is. And I do want to say one other thing, Dr. Williams, as well. Another statistic that really jumped out at me, and I thought maybe this is how we introduce this, is it the 2 out of every 3 people, they're in kindergarten today, and they're both people of color, are the ones that are going to be paying for Social Security. I had not heard that one before. But certainly when you look at polling around sort of how important is Social Security and Medicare to people as they're getting older, I mean, it polls really, really well. So somehow that statistic has to get out there, I think.
I'm going to ask this one of Dr. Williams. I heard in your talk that one of the strategies is to build racial pride, and I wonder what your thoughts are of the university, what else we might be doing to achieve that.
I don't have any magic bullet building racial pride. I would add that the specific body of research on racial pride that I drew on that shows programs that build racial pride into the curriculum with interventions have positive effects. But there's a related literature on values affirmation effects that comes out of, I know it's viewed as somewhat of a solution to Claude Steele's earlier work on stereotype threat, and that values affirmation intervention that are done with 8th graders in the early studies. 8th graders are randomized to a single class period writing exercise where they write about a value that really captures who they are as a person. And this in the study published in Science, found that these values, a single values affirmation exercise reduced the black-white gap in academic performance by 40%. A similar study done later with Stanford undergraduates using a slightly different strategy, but again, it's one affirming them, reduced the black-white gap in academic performance by 50%, led to improved grades over the entire 3.5 years that they followed till they graduated, and also led to both improved health but fewer visits to the University Health Service over 3.5 years. So there's a wonderful review paper in Annual Review of Public Health by Cohen that reviews these values affirmation interventions and suggests there's promise. There's one with Latinas in college that found one of these values affirmation exercises led to, in the intervention group, smaller gains in weight over a 2-year window than the control group who didn't get it. And that these values affirmation interventions, while they don't change the individual's accuracy of perceiving stressful experiences, it reduces the threat they see from the stress, so they feel better able to manage stress, and that might be the pathway towards some of the behavioral changes that has been seen. So again, I think it's an emergent area of work. I don't think there's a ton of studies. I think what has gotten the attention, that the findings are so striking that I've shared them with some colleagues, and it couldn't possibly be right. I mean, you couldn't get effects so dramatic from such simple interventions. But I think the available evidence suggests that these have particularly powerful effects. And I think if you look at the values affirmation intervention, what they argue is operative, is trying to build a sense of adequacy and a sense of affirmation that I am capable and I am able to do things. And if you do it in ways that are subtle, the students don't remember the exercise per se, but we see fairly dramatic effects of its results. So I think there are great researchers here at Michigan that can test to see what might be done within this context and could build on some of those findings. But I would emphasize there's a larger literature out there kind of consistent with the racial pride findings.
My next question is for Dr. Williams. You mentioned a little bit about philanthropy in your talk, and I was just curious about what role do you think philanthropy can play and health disparities and trying to...
Should I answer that question? Jim Marks is in the audience. Jim Marks was a senior vice president of the Robert Wood Johnson Foundation, the largest funder of health-related work in the country. He's now retired to Ann Arbor, so he's not in his role. But I think, Jim, you might have some good reflection of. Okay, Jim is my lifeline. It's been great. I've worked with him, and he has been a great colleague.
So I view the central issue of our country is how do we embrace differentness rather than turn it into a strength. Because we have greater variation than almost any other country, and rather than a source of divisiveness. I think a central issue has been that of a feeling that is exacerbated by some groups that another person's success is at my expense rather than it's all together. At the foundation, we, David was a big driver, we felt that the whole issue of social determinants, first of all, we looked at what we were spending our resources on. And well over half were on issues of disparity and equity. What we often didn't call it. It was called in other more narrower single projects. We needed to elevate that perspective. We also saw that some of the things that were most important were social determinants. And that was not getting the priority and attention that it needed in the nation. Most important for health, and we increasingly added the term well-being, so that it didn't drive people to the medicalization issue. The report David was provided the staff leadership for helped to get that visibility. It influenced the issue of food deserts and getting supermarkets into the inner city. That commission went in and looked at that was in Philadelphia. The Federal Reserve Board, the community development part, approached us after the report came out because it was that commission that first looked at differences in life expectancy by geographic area. Wherever the country went, they did life expectancy by zip codes or neighborhoods or things like that. And the Federal Reserve Board Community Development Group said, well, we're in the zip code improving business. We should be talking with the health community, and it led to a lot of change. I think the issue of philanthropy is, A, it can take a long-term horizon. That's really important. And B, it can help frame the issues at a higher level rather than a project. Then their projects can fit, but those are the things that should be doing most influentially, if you will. I loved David's emphasis on empathy, because that was one of the things I was trying to get the foundation to think about before I left. And I would add one comment. When you talk about the fact that one of the two workers putting into Social Security is going to be minority, they've got to have great education, great jobs, and they've got to care about old people.
I'm thinking about the market development of the gap in 5 to 10. And I'm wondering, are there any best practices or interventions that we can use in how to speak to children about race in order to combat that development of the gap? And if so, what we can learn from these interventions and how to speak to ourselves and adults who are already developing.
I think I heard the question. So it was the empathy gap is evident at age 10, and what can we learn from best practices and so on. I don't know that I'm the expert on best practices with addressing the empathy gap in very young children. I would say what I know empirically to be true from research is that, and I think it was on one of my slides, of one of the things that reduces the other race empathy gap that seems to be a universal phenomenon is greater interracial socialization early in life. And that is consistent with studies of looking at the desegregation of education that shows that kids who go to schools where there are persons of more diverse background, that shapes their levels of tolerance for their lifetime and gives them greater openness to others who are different. So that's one factor I know. There may be others, and there may well be people in this room who know this specifically specialize in this area. But one I know is early interracial socialization, included in educational context specifically, has been studied. It has long-term effects, and which was consistent with the work that review was a review paper of global studies that found early interracial socialization has a long-term effect and minimizes the likelihood of this same race empathy alone challenge.
We have time for one last question.
Hi, thank you for your remarks on the panel. I'm interested in developing culturally relevant mental health interventions, particularly for Black women, but marginalized folks broadly. How would you suggest, especially Dr. Watkins, we bring attention to the need for this, especially on a national level, given this political climate of increasing culturally relevant mental health interventions?
That's a big question. Maybe we can begin the conversation now. We can talk about it a lot more later. I think that no one can argue with good science. I think starting from where the gaps exist and trying to fill those gaps is a place of need. I think that there are ways to make sure that you, I don't want to say convince people, because I don't even know if that's always the role when you're trying to represent marginalized communities, but at least partner with communities to the powers that be, such as people from the Robert Wood Johnson Foundation and others, to tell their stories. My sense is that when it comes to foundation support, I think the stories are really important. There's also a need for support from the federal line, and so I think that if you start with good science, really trying to fill the gaps, I mean, no one can really complain about that. That's my take. I found that I had some challenges earlier on trying to convince people of the importance of Black men's mental health. Had lots of editors and journal reviewer or grant reviewers say no one cares about Black men, or no one cares about Black men's mental health, or my favorite, where's your white comparison sample, right? And so I think that just sticking with it and not giving up. And as Bree mentioned earlier, just making sure that you sort of, I think she said, push the doors down. And I would argue to kick the doors down where need be. Because I think that's necessary, and the people that you're trying to help, they deserve the best science, and they deserve the best of you.
Can I just add one thing that I think as we work with disadvantaged communities and we think of building community capacity, I actually had it in my slides, but I deleted it because they were too long. We actually need to think of what we can do to promote community, both individual and community mental health and well-being. And we need to think of this across the age course. There was a study, I was mentioning it to the dean at lunchtime, that I am still trying to grapple with what the findings are. It's a study that looked at rates of suicide among elementary school children, national data on the rates of suicide among elementary school children. And over the last 20 years, there's been a decline in the suicide rates among children aged 5 to 11 for whites. The rates have been stable for Hispanics. The rates have more than doubled for African Americans. It's one of the few examples we've seen in the literature where we see higher suicide rates for African Americans compared to whites, but with the trend, and I don't know, when I was 5 to 11, did I even know what suicide was? And to see this striking, and the question is, what is driving this? And maybe we need to step back and ask, what does it mean to be a Black child growing up in America today? Some of my research has documented, work with Brandisha Tynes, that children of all racial groups, but particularly minority children, experience a lot of discrimination in online contexts. Other work I recently published last year with one of my former students, Jacob Bohr, that documented that every police shooting of an unarmed black male leads to worsening mental health for the entire black population of that state for the next 3 months. So all of the stress, and you look at some of the Southern Poverty Law Center's reports on the impact of the presidential election on the health of kids K through 12, and work from the Southern Poverty Law Center as well, that documents the #1 site for incidents of harassment and intimidation in the United States is K through 12 schools. So I do think we need to think broadly about all age groups, but really what is happening to America's children, what is happening to minority children. One last story, since stories are good. In the Southern Poverty Law Center report, on the presidential election, there was a kindergarten teacher in North Carolina who reported that one of her kindergarten students, a Latino boy, came to school every day and asked his teacher, "Is the wall built yet?" Because his classmates had told him that we are building a wall and you're going to be stuck behind that wall and not be able to come to school. So what does it mean to be 5 years old and worried about the wall every day? So I do think that the mental health challenges we face now are serious, but in the current environment, we have to be concerned about even what does that mean, and what are America's children understanding and experiencing as a result of living in this very hostile environment, and think of what are the mental health interventions that we can help school districts with, principals with. How do we build contexts and cultures that are supportive and open to value diversity and value difference and support each other?
So as we close, I want to mention one quick thing. The panel and Dr. Williams will be here for a little while for individual questions, and also in the lobby we have a lot of great food waiting for you. So feel free to come to the panel. I didn't even want to. Let's give our panel Dr. Williams one more round.